All right, hi everybody, thanks so much. Okay, so as Ted said, I'm going to be talking kind of a little bit more functional neurology, if you will, which I'm a huge fan of. And the talk is about fusing the image post-traumatic brain injury, so a neuro-oriented perspective. And all that really means is I'm not an optometrist, right? So if I'm talking about aphoria, I'm not going to be writing a prescription for a set of prisms. I'm going to be actually working the person. And I tell a lot of my patients, you know, it's going to take work, but we can fix this. So disclosure, I have no financial disclosures. This is a common slide for me, and it's part of the brain-eye axis. So if you look at that slide, you see vertical bars, like a, opticokinetic nystagmus. But if you shake your head, does an image kind of evolve? Okay, hopefully some people are seeing a cat in there, all right? Now, this one is a little harder because it's a diagonal. So if you shake your head, you might or might not see it, but if you shake your head, to the side, hopefully the number 17 starts to resolve. These are just easy, simple demonstrations that the eyes and the brain need to communicate. Sorry for my bad, sorry. The eyes and the brain need to communicate, and the eyes may be sending information, but what is the brain doing with it? And I use this as a demonstration for patients as far as they can see things and read, but maybe not remember. And that's just a discussion that I use early on with many patients on the eye-brain axis. So traumatic brain injury and neurovisual issues, I'm going to be focusing on number one in this slide, and that is fusing the image. We're going to go a little bit into the reaction time and a little bit into photophobia because they do start to come together as far as the brain-eye axis, but I will be kind of emphasizing the aphoria component because that's putting the image together. So one of the devices that I use is the Dynavision D2. The Dynavision is an eye-hand coordination thing. Again, I have no financial interest with Dynavision. It is multimodal. It's based on the old Wayne saccadic fixator as far as the position and the distance for the eye function, but then it has an eye-brain axis component to it, and at the very center, it has a tachistoscope right there, and that will flash commands or words or math problems so that while people are doing an eye-hand coordination program, they're actually seeing and thinking as well. So it's multitasking. And because it's got the buttons way on the outside as well, it makes them use their peripheral vision during this type of training. With regard to fusing the image, everyone will think, aphoria, esophoria, strabismus, vertical aphoria, that type of thing. And believe me, that is a part of it. And I don't want to dwell on that too much because I'm hoping most people have a decent feel for that. I'm going to go into it a little bit as far as phorias and alignment of the eyes. Neurology and optometry and functional neurology, we actually all have different languages, so I will hit that a little bit. If it's too much old news, just somebody tell me to skip it. I mean, literally, we can skip it. So hopefully this is old news for most people. But ortho are the eyes parallel to the ground, parallel to each other. And when we're ortho, we have about 180 degree field of view limited by anatomy. There's this whole part of our peripheral vision that is not limited by anatomy, but it's limited by our ability to perceive what's going on. And I will say, in my patient age group, which is high school and college and young adult, their peripheral vision sucks because of these things, okay? They spend their lives on phones. That's another subject, but you may want to limit phone use for people who are post-traumatic brain injury because they'll be over-converging, which could be a version of this. Over-converging is over-adducting. So this would be, say, a left eye esophoria type of thing where the left eye is turned in a little bit. Often because of the phones, both eyes are over-converging or turned in. And that person's going to be losing depth perception. They may be suppressing that left eye. It could be ocular motor. It could be motor cortex involvement. But when you see that, there's multiple ways to try and address it and multiple reasons for the cause. And believe me, too much media use will make them feel worse and slow down their recovery. And the worst thing you can say to a younger patient, okay, don't use your phone. That's hard. It's really hard. But they may need to minimize their phone use. Okay, so these are some of the tools that a lot of people use: neurology, functional neurology, optometry. I want to, with regard to like little cooking tips, I actually have a phoropter in my clinic. And I don't use it, like I said earlier, to prescribe prisms. I use it because I have them fuse the image. So in other words, I have them look at something that's, say, phone distance away, 14 inches, or farther away, 10 feet. And I'll fuse the image for them with the prisms, and then move the prisms in whatever direction is making their muscles move to exercise. So if they're over adducting, I'll fuse the image with the prisms by making the prisms ISO or in, and then actually push them so their abductor muscles are coming out. Okay, so I'm moving the image on them. And so I literally use the phoropter for eye muscle exercise, eye muscle rehabilitation. And I guarantee you, you will give somebody a raging headache, but they will feel better in the long run. So be careful. I usually only do it 1 minute at a time, 3 minutes, 3 1-minute sessions over 20 minutes, not a lot. I also use the phoropter for a headache assessment. So if somebody has chronic daily headache and they come in and they see me and it's like every day at school at math class I get a headache. When's math class? 11 o'clock. Well, is it math? We'll do like some math problems. No, I'm pretty good at math. I put them on this, and it turns out that they're actually on math class. They're in their book or they're on their computer the whole time more than other classes, and they're over-converging, and that's giving them a headache. And I can literally recreate their 11 o'clock headache with the phoropter. And then we know we need to either change the exercises, or there are different things that we can do to help fix that. To have stereo vision, one of the tests that we use, a lot of people use, are the stereo fly, and I hope this is kind of old news for people, so I won't dwell on it too much. The stereo fly assesses depth perception. It's quantitative. So if you're treating a patient who has a difficult time fusing the image, you want to see how far off the page they think the fly's wing is coming. You give them a pointer and say, where's the farthest point away from the page the fly's wing is coming? It's measured in millimeters. Normal is 20 millimeters, okay? So that's average, I should say. So normal is actually 15 to 25. As Ted said earlier, I actually do stuff with athletes. We actually vision train our athletes. We get them to 45 millimeters. So depth perception improves. So the stereo fly is quantitative. A lot of optometrists don't use it. It's like, look at the stereo fly, is it in 3D? Good, next. So I like the stereo fly because it's very quantitative. And there are tons of publications on that if anyone wants them. This is kind of what I just said, that you can use the stereo fly quantitatively in millimeters. There's also things like the Randot and the tranaglyphs that they do similar things. The tranaglyphs are good because it can help you go adduction or abduction. In other words, ESO training or exo training, because they go in both directions. So where's Jessica? So what this is these are Bates field splitters. That's the picture on the screen. And you can do the same thing with 2 different colored 3x5 cards. And I have these because sometimes people are wearing glasses. So you have the person put the glasses on and look at something 20 feet away, so which is like ortho or past the hyperfocal length. And there's 2 colors, and they should see the 2 colors. If they're seeing the 2 colors, awesome. That means they actually have the possibility for binocularity. But the other trick from the central perspective is there's bluish green on this one, the lights are kind of funky, and pinkish orange on this one. I don't know if it's peach or not. When I put them on, the peach that is here, I see over here because of the crossover of the optic chiasm, right, the perception. So I'm perceiving the peach coming from over here and the blue coming from over here, which also means I have a normal functioning crossover and optic chiasm. So what happens if you have somebody who's suppressing? Well, I will I will have somebody recommend them to go to Arts and Crafts or Home Depot, and these are just safety glasses, a little bit of blue tack that's used for putting pictures on walls, and some clips and 2 colors. And they get a homework assignment. It's the hardest homework assignment in the world. Watch TV. Go home and watch TV. And I just asked for the TV to be as far apart as possible. If you have a significant other, make sure they ask you every once in a while, do you see 2 colors? Do you see 2 colors? They're not suppressing. So we're training away the suppression. It's an awesome homework assignment, these are called Bates field splitters, invented or developed by William H. Bates in the 1930s. Continuing things for near-far suppression. So I liked part of yesterday's talk where people were talking about the devices are great, but make sure you use your clinical skills and the simple things. So here's a simple thing. This is a Brock string, okay? So I use the Brock string for training fighting suppression as well as assessing it. And so my methodology for testing suppression is I get somebody and I say, okay, where do you use your phone? And they're like this. Okay, so let me do this sideways, like this. And then I have them hold the Brock string with a bead at that same distance. And the instructions are, look at the bead. Do you see the bead? Yes. Is it in focus? Yes. Do you see 2 strings? Hopefully, yes, because both eyes are working. And then you ask them, okay, if you see 2 strings, do they cross? Yes. Where do they cross? And I have them point. And I'm not sure I can do this with one person. So I point to the bead. If they point before the bead, they're over-converging. If they point after the bead, they're under-converging. In other words, the ESO versus possibly EXO. Again, it's where they're fusing that image. Now think about that. I've had people who are over-converging at 14 inches by 6 inches. So in other words, they're focusing here, but the eyes are converging here. And then they tell me, well, they can't study. Yeah, no kidding. Okay, that's a tremendous amount of work for the brain. And so what we need to do is we need to do the A-B duction exercises. And this is extremely simple. And then what I do is we've got multiple beads on there. We have them change distance. Look at the first bead, 2 strings, the strings cross at the bead. Next bead, 2 strings cross at the bead. So the Brock string can be used as training and testing. And again, you can have people take it home or make one at home with just a knot, and they can literally see how tired they're getting. In other words, as they're studying, if they're working up close, it gets worse and worse because that's the way the brain is tending to have the eyes go, and it makes them take a break, or it's a trigger to make them take a break. So if they only see 1 string, they're suppressing. You cover one eye, the string that jumps, that's the eye that was working, the other eye was suppressing. Okay, so in other words, if I'm looking, I cover this eye, oh, wow, the string jumped. That means this eye was suppressing. When I covered this eye, which was working, the brain started using the other eye. So you can figure out which eye is suppressing. The other trick is that's near suppression. So how do you assess far suppression? Because that can be a different calculation for the brain and what's going on post-traumatic brain injury. Well, the technique that I use is euphemistically called the thumb thing. So I'm looking at the camera that's straight ahead, and I bring my thumb up. I should see 2 thumbs when I'm looking at the camera. If I don't see 2 thumbs, I'm suppressing. I cover one eye. Whichever thumb jumps is the one that was not suppressing. So in other words, I was using that eye. If it jumps, that eye was the one that was not suppressing. Sometimes people use this, will say, I don't see 2 thumbs, but they actually do. So then what I say is, okay, can you cover that object? Well, no, the thumb's transparent. Okay, it's just they're not quite sure how to describe what they're seeing, okay? The other thing that I also do, especially with athletes, is they get used to how far apart the thumb should be. Because if the thumb starts coming in, they may be starting to over-converge if that's what they're tending to do. And again, these things make that happen to people. So a trained person, a person that does regular vision training or rehab, knows how far apart their thumb can be. And I've done this with myself. By the end of the day, my thumbs are actually coming in because, yeah, I'm fatiguing. I spend a lot of time on a computer doing up-close things. So it helps me, and it helps the person or the patient know that things are kind of coming in on them as they're going through rehab post-traumatic brain injury. So fusing an image, making sure a person has stereo vision, we want two eyes to work. Well, strobe glasses are great for that because a lot of us may have learned using stroboscopic lights to flash things at people. Obviously, be careful with regard to seizure frequency. These strobe glasses can be used for treating suppression because it's like annoying the eye. It's telling the eye to stay on. So whatever eye is tending to suppress, the strobe glasses will start flashing. And if you can see that, the strobes are flashing, and so it's interrupting their image. And these can actually cycle through, so you can use one eye or the other eye. And so you can work one eye or the other eye more or less with the strobe glasses. These are nice because they don't go faster than 10 hertz, so you don't have to usually worry about a seizure frequency. I have some that go a lot faster towards the 20, 25, 28 hertz seizure frequency. I use them for specific testing, but usually these are Vima Revs, the Nike Spark, the Synaptech strobe glasses. They don't go so fast that you have to worry too much about the seizure frequency. I still ask people before using these if they have a history of seizure disorder, and as long as they don't, then we'll consider trying these. And they're going off. Okay, so continuing with making sure both eyes are working, fusing the image, getting the image from the eyes to the brain, two-color glasses. Now, this should be old news. There's only one caveat that I want to express. When you're using two-color filters, some states the optometrists are fairly picky about what's their purview and what's the scope of practice, so obviously check your local provider. But red and blue glasses, red and green glasses, they're different colors, will filter out different lights. Different colors, excuse me. It works different if you're on a piece of paper versus on a screen. And the NSI booth that's in the vendors, they actually have a pair of these glasses that I loan to them for anyone who wants to see. And you can put the glasses on and look at the screen, and you'll see that you'll get a better picture of one color versus the other through different eyes. You can give people tasks that use two colors, and it makes sure they're using both eyes. Okay, which is great. It works different if you use it on paper. Okay, and what I mean by different is often with the paper, red will filter red, whereas if you have a light, a beam of light, a red light through the red filter enhances it. So some of it's the negative, some of it's the positive, which is great. So then you can have people work on paper or on a computer screen. These are some of the, this is an example of one of the saccadic eye charts that you can use to make sure a person's using two colors, which I'm going to demonstrate in just a second. Wrong way. Yeah. So with the two different colors, imagine you've got the two saccadic eye charts and a person is reading left and right, and they have to use randomly one eye or the other. If it's going to be random, then they're going to keep both eyes on. So you're fighting the suppression. Okay, so a little bit more about the neuro rehab. So if a person comes to me post-traumatic brain injury and they're complaining of photophobia or photosensitivity, I don't want to get into the semantics of the difference between those two. Excuse me. A lot of people will be wearing sunglasses. Now, from a neuro perspective, I'm okay with sunglasses, but I don't necessarily like them because they take away all of the information to a certain point. They cut a lot of sensory information. Humans perceive, from a sensory receptor perspective, white, red, blue, and green. And so we use colored glasses to see if they're only sensitive to certain colors in the color palette, and that way they're getting a normal amount of information from other colors, and we're just helping them feel better with the colors that are bothering them. And this we can do empirically. In other words, in my clinic, I've got a whole bunch of colored glasses. I'll have them look at overhead lights if that's what's sensitive to them, my pen light or whatever, and then put on the colored glasses one at a time and which ones make them feel better. And it works pretty well. So about 85% of the people who have photophobia end up with some relief with the colored glasses. And I've literally had patients in tears saying, I don't want to leave without these. Can I buy them off of you? And the university has rules against that. I can't market that way. So, they have to get them through Amazon. But in Cincinnati, we've got an Amazon hub so they can be there the next day. And if it's early enough in the morning, they can actually get them that day. They're not the specialized filters, so I checked with optometry locally, so I'm not stepping on toes as far as I'm not prescribing filters. I'm just saying this color seems to help you. And not surprisingly, it's kind of the RBGs that are most often involved in relief. And it's very easy, and it helps a person feel better pretty quickly. So a little bit of how we manage the photophobia is I try not to take away too much from a person's life. So they can wear sunglasses when in the sunlight or when driving. Many states you're not allowed to wear colored glasses when driving. They might filter out red lights for the police, so you want to avoid that. And be very aware of that. But then using the colored glasses when they are in a situation where they cannot control the light. I've even had patients where they changed all the light bulbs in their house. Okay, if it's going to help them feel better, that's great. And these are fairly simple tricks to help them feel better and see better and be better post-traumatic brain injury. 15 minutes? Okay, just checking. Thank you. All right, so we're getting back to this the saccadic eye movement. Remember, I'm fairly brain-centric. Saccadic eye movement is fairly straightforward as far as left, right, up, and down, and that's wonderful for the ocular motor. But a lot of people report they're not remembering what they're reading, and reading is a version of saccadic eye movement. So we can do the saccadic eye charts like this, where there's two charts separated by a distance. The distances are flexible, but usually no more than 90 degrees from the center, because that's getting really hard. Often much closer, because especially for academics, you just want to read in about a 10 or 20 degree field, right? So that's fine, 10 or 20 degrees. The flexibility is up to you and your patient. But how do we get them to start remembering what they're reading? All right, I've embedded words in these charts, so let me see if I can do this. If everyone read out loud with me, top left, N, and then top right, this would be separated, I, N, E. I just spelled 9, okay? So there's words embedded in these charts. So this is a way for a person to start remembering what they're seeing when they're doing saccadic eye movement. So, and we continue, B, L, A, C, K, black, okay? 8 is just the separator. D, I, R, E, C, T, direct. Oh wait, I, O, N, direction. S, directions. This is actually a super hard one. Usually when I'm starting somebody, it's maybe 2 and 3 letter words, so I can start putting them together. But this is training somebody in a neutral situation to short-term remember what they're quote-unquote reading. They're calling them out loud because I need to hear what they're seeing because they could get lost. And then they're remembering the words as they're going through them. And believe me, as they get better from 2 words on charts, 3 words on charts, and this is multi-words, and each column has a series of words. They need to be matched up. Their reading gets better because we're training them to remember. But they don't need to remember the whole story or a textbook. But that's where the brain-eye axis comes in, right? For me, this is kind of a cornerstone of the functional neurologic part of what I'm trying to do to get a brain-injured person better. The optometrists are great with saccadic eye movement, but from a neuro perspective, if I can say we want their brain to recognize what their eyes are doing. And this is one of those little tricks that can help do that. These are available through Bernal. I try to make them for patient specific, so it's often got, sports related things in them. And because it keeps them interested, right? If it's something they're used to, it keeps them interested. and they work wonders. These are literally just made with a table and a PowerPoint. The table function in PowerPoint, it's a 10 by 10 grade. So I can actually measure how far they're going along. When they get really good, I can tell them, okay, do 5 rows. Then after you're done, how many words do you remember? What are the words that you remember? Because again, I want their brain to recognize what their eyes are getting. And it really does work. It's very exciting. Can you tell? I'm excited about this. I like this stuff. So I sort of addressed this earlier with regard to the Brock string and the thumb thing for near-far suppression. I do want to digress a little bit with regard to near-far suppression. If you suspect somebody suppressing, make sure you do both. I've had people, and it took me a little while to figure out, that would suppress one eye near and the other eye far. And what happened is, this happened to be a female patient, and she had a traumatic brain injury, but she was one of those people where she had needed glasses. She needed one prescription for reading, one prescription for distance. She didn't want bifocals. She didn't feel comfortable with progressive lenses, so she had one lens for near, one lens for far. It turned out for her, it was pre-existing. She had trained her brain to suppress one eye far and one eye near, and had no stereopsis. And I'm thinking, oh, well, I guess I don't need to try and treat that. I'm not sure I would have chosen that, but the optometrists will do that. But you do want to, it does occur for other reasons, but that's just one of the reasons why it does occur. And I've seen several patients like that. I guess a lot of people, it's hard to work the progressive lenses or the bifocals, and they just have one eye versus the other. Okay, so palming, the top one. I do palming for myself because I can spend a lot of time on a computer. When a person is getting eye fatigue, tired in clinic, or they need to, say, work, if I'm working with an athlete, and the athlete has poor study endurance. I use that expression a lot. Do you have normal study endurance? If not, a very simple, and we're all going to do this in just a second, a very simple way to take a break and relax the eye muscles, if that's a component of it, like they're over-converging, under-converging, and it's working too hard, maybe with saccadic eye movement, because that's what they're not good at. A really easy way to help relax the eye muscles, and it takes a 2-minute break, is, everybody watch for a second, I'll demonstrate. You take your palms, and you put them in your eyes, and you push gently. And you alternate every 10 seconds. You 10 seconds look to the left, 10 seconds look to the right, 10 seconds straight, 10 seconds up, 10 seconds down. It takes 1 minute. Now, as all of you know, some of the muscles are going to be shortened, but some of them are going to be stretched, and then they're going to be moving, and our eyes are not perfectly round. So you're literally massaging the eye muscles, and it's a great break for the muscles when somebody's studying, and a 1-minute break can get them back to studying. And if it's okay, I really want everyone to do that for 1 minute. Don't push too hard, no pain. So put your elbows on the table in front of you, rest your hands on your and the palms of your hands, and through my instruction, so 10 seconds straight, 4, 3, 2, 1, 10 seconds left, 6, 5, 4, 3, 2, 1, 10 seconds right, 6, 5, 4, 3, 2, 1, 10 seconds straight, 5, 4, 3, 2, 1, 10 seconds up. It may feel weird, don't push it, because humans want to open our eyes when we go up, but everyone's going up at 5, 4, 3, 2, 1, 10 seconds down, look down, 6, 5, 4, 3, 2, 1. And relax, sit back, open your eyes, blink a little bit. Some people it may be blurry because you slightly change the shape of your eyeball, but that'll resolve quickly. That's super relaxing. If you've been studying or working or overworking your eyes for a while, it can be very relaxing, and hopefully a lot of you felt that. And it's a great instruction for people to do as part of a homework, or if you're in clinic and they're getting a little fatigued, you give them a break. And I took my glasses off, I can't see. There we go. Okay. Okay, so I want to show a little bit of data and then justify why I think the data are important. So central and peripheral vision. So peripheral vision is not only in the purview of the optometrist, and I'm not slamming the optometrist, but when I tell people I want to train peripheral vision for an athlete or for a concussion patient, there is sometimes a little bit of pushback. It's like, well, you're going to overload them. Yes and no, because we're training the brain. When I say vision training, I'm also always thinking brain training. But many traumatic brain injured people, their reaction time slow down, but their peripheral vision, they can be getting tunnel vision or difficulty processing in the periphery. So what we have is, again, we use this with the Dynavision, and it can be done with several other modalities, but we measured central to peripheral vision, peripheral being 45 degrees off center, okay, laterally, because you could be getting close to the blind spot. Normal humans have a central reaction time of about 0.3 seconds, and their peripheral reaction time laterally in either direction is slowed by about 25%. Okay? Hopefully that's not a huge surprise to people. This is not a movement thing, this is a flashed image, so that's where the slowing comes from when you're off center, and again, as it says there, it's about 45 degrees off center. So, 0.3 seconds, 0.29 seconds, that normal of about 20% slower in the periphery, not a huge surprise. However, concussion patients are slower. So if you look at the data here, there it is. The concussion subjects are 0.36 seconds compared to 0.29 seconds, and that's significant, statistically significant. Should not be a surprise. People are foggy, people are slow, reaction time slow down, yes. Peripheral vision is slower from central to peripheral in normal people, and even greater slowing in concussion people for central to peripheral. They're over 36% slower in the concussion or traumatic brain injury patient. Now, obviously, with traumatic brain injury, it's not equal on both sides. So actually, about 60% of those people that had slowing, the slowing is more on one side. So I'm getting hemispheric information from these data. The percentage was highly statistically significant. So in other words, if you don't have a baseline or a history with a patient, you can use the ratio. You know what their central is and how bad is their peripheral. And if the peripheral is asymmetric or much greater than 35%, because that's a mean, then you're suspecting they have a concussive event or something that's contributing to their symptoms. The one thing I do want to add on this is when we do vision training in healthy individuals, so our athletes, their central reaction time gets faster, their peripheral reaction time gets faster, and the ratio gets much better. It's only 6.9%. So in other words, they're taking in more information and they're using it very effectively. Okay, so that's what happens when you do the vision training. So the conclusions with regard to the central versus peripheral vision is that A, visual reaction time slows down, not news. B, peripheral reaction time is slower than central reaction time at 45 degrees off center, also not news. C, when you do vision training, you actually can get in more information from the periphery, use it better and faster. And then with traumatic brain injured patients, they can be the ratio can be substantially slower. That can impact their quality of life and their activities of daily living. So picture, if you will, if you're driving a car, if a person's been cleared to drive, and it's taking 0.5 seconds from an image to get from here to the brain compared to the central. In other words, a car's coming, and I perceive it out here at the same time it arrives here. That gets very confusing, and we believe, our thesis is, that can be contributing to some of the temporal distortions that people have. their timing has been changed, and it can make them very anxious with regard to things like driving. So we actually will include central reaction time for a driving assessment, as well as peripherals. Because if their peripheral is really slow, even if their central is okay, that could be a concern and go into the metric for not wanting them to drive just yet. So next 2 slides, and then I'm 2 or 3 slides, and then I'm done. I presented last year, but I want to use this for traumatic brain injury. So getting information to the brain. So basically, you're going to see a flashed image on screen, and then we're going to ask for information off of the image. So everybody look at the screen. Ready? Okay, so that was very fast. What did you see? All right, football player. Was there an alphanumeric on it? 1, 2, 3, 4. Okay, so anyone get the player on the left? Number 32, okay? So we're gonna do one more of these to see how it can progress. So I'm training a person to see and perceive. That's getting the neuroinformation in. What'd you get? It was much harder. So this alphanumeric, people can get with practice and describing the image. So again, my patient population is young adults, high school and young adults, and often they're in college or school. They need to get visual information from their professors, often in slides like this. This is also a way to get them back to their academic abilities, their academic capabilities. So we put these things together. Sometimes I'm doing this with one eye or both eyes to help them use both eyes to be able to get that visual information. The last thing, Ted, is with eye patching. So I will eye patch people, but when I eye patch a person, I want them to get visual information. So this is an example of a pair of glasses that I use for eye patching, but I put in an artificial horizon. Okay? The artificial horizon is because I want them to get information, but then they're training the other eye, and then I can switch these up. The other is I use a version of these and picture the horizon tilted. So if I put a pair of horizon glasses on them, as we call them, and tilt one or the other image, and they start tilting their head, that means there's a VOR problem. It's just pointing me in a direction that one eye is using the horizon for their balance, and it's not being reconciled, whether it's an otolith problem or a canal problem or a visual problem, but it points me in a direction. And again, very simple tool. And then I always do the horizon thing before I start doing the eye patching for training, because I don't want to have a person off balance when they're, say, doing the T-scope training. All right, thank you very much. I appreciate it.
Perfect.